physician in Delhi, India, and I run this channel, Young India Intensivist, on YouTube, which is a free channel for critical care education. Now, I'm going to be talking about basic hemodynamics in terms of arterial pulse and tracings in the ICU. So something more dynamic, more acute, and really cutting the heart and the sword here. So if we look at how blood pressure began, it was in 1733 when Reverend Stephen Hales measured blood pressure for the first time. As you can see in the picture, he cannulated the artery in the neck of a horse, connected to a big glass tube, and you can see the blood rising. And for the first time, it was demonstrated that there is pressure in the blood that is there in animal and subsequently human beings. So today we are 300 years down the line, and we can now predict a fall in blood pressure before it can actually happen. And that is with the use of AI. So that is how things have progressed in the last 300 years. Progress in medicine is a slow game. It does not happen overnight. Now, a very basic slide I put up for you guys, that is the pulse. So we are all taught in medical school, medical college, always examine the pulse. And very sadly, this is dying out. So friends, please check the pulse, put the finger on the pulse, whether it's low volume 3D, indicating a low stroke volume, whether it's bounding, indicating a high stroke volume, whether there's a pulsus paradoxus disappearing in inspiration, straight away telling you likely cardiac tamponade or maybe increased respiratory efforts, pulsus alternans, telling you there's a poor LV, dysfunctional LV, irregular pulse, telling you there's a arrhythmia. And if you get a high volume pulse and the radial artery is feeling rigid, you know there's atherosclerosis. Now, this is just a 2-minute thing, and sadly, this is dying away. Now, in the world of AI, which is coming up very strongly, as long as you examine the patient, no AI can take away your job. But if you stop examining the patient, this might be a real danger in the coming time. So moving on to another very basic thing. So I'm trying to give you some pulse from my experience in the ICU. The patient is in the ICU and there is suddenly a tachycardia, sinus tachycardia, heart rate jumps to 130, 140. So there's this mnemonic I have kind of constructed myself, chip, VAT, cash. So here, you have these causes. So if you kind of go through this list here and try to focus on the patient, you get to know why there is a tachycardia. And you don't have to do a battery of investigations. You can then just proceed and focus on what is wrong and order the investigations accordingly. A very simple mnemonic, chip, VAT, cash. And this is not an uncommon thing. Tachycardia develops very often. And you can see the causes here: cardiac disease, disease cardiac output, ischemia, hypovolemia, inflammation, sepsis, surge, so common. Then the patient has gone to severe pain, fever has occurred, anxiety, which is not always discernible, drugs, catecholamines, you start ignoring NORAD, tachycardia is occurring, and sometimes seizures. The seizures are not always overt, right? They are non-convulsive seizures. Patient has started bleeding, there's a silent bleeding in the GI tract, and shock is occurring, hypoxia, hypercapnia. So all these things, which there's a very big list, but this mnemonic can be very helpful. Now coming to hypotension. So we are very well versed with the idea that hypotension is accompanied by tachycardia. But if there is bradycardia, again, it's a clue to diagnosis. Very simple and very straightforward. So what are the causes? Beta blocker overdose, calcium channel overdose, amidrone overdose, or maybe not even overdose. Just normal dosing can cause such a situation in some settings. Then neurogenic shock due to something like a spinal trauma or a spinal anesthesia, or even a brainstem insult like a brainstem stroke, because the control is there for the circulation. Then there is mixed edema, coma, massive pulmonary embolism because of activation of basalt gyrus reflexes. So these are certain reflexes which are there in the ventricles and they cause bradycardia. Poisonings, cardiogenic shock, and I'm sure the audience is very well aware of this: cardiogenic shock, inferior wall MI, complete heart block, and so on and so forth. Neurocardiogenic syncope because of so many causes, and severe hemorrhage again because of basalt gyrus reflex. So this reflex is very important, basalt gyrus reflex. which originates in the ventricles and can lead to bradycardia in certain situations which are catastrophic. Now, coming to another clinical clue, can septic shock present without sinus tachycardia? We all know shock is accompanied by tachycardia. I showed you some situations, but that was not septic shock. Septic shock, we have all seen whatever field we are in, right? Can this happen without sinus tachycardia? So septic shock does not happen without sinus tachycardia. That is classic septic shock due to bacterial infection. Sometimes due to viral infection, sometimes due to fungal infection, there may not be tachycardia, what can be called a relative bradycardia. The situations in which septic shock does occur without tachycardia is if there's an intrinsic sinus node dysfunction. For example, there's a sixth sinus problem, sixth sinus syndrome, or the patient is again on beta blockers, calcium channel blockers, amidrone, patient is hypothyroidism. So these situations, if they are present, then the patient can have septic shock with a relative bradycardia. And these are the patients who should be given dopamine. That is the only indication to give dopamine in septic shock patients. That is if they have shock with bradycardia. Now, coming to another clinical pearl, from my experience, low diastolic pressure is considered synonymous with septic shock in 95% of the patients, or a vasodilatory shock. But please remember, there are many other causes. For example, any condition which causes systemic inflammatory response syndrome, such as acute liver failure, acute pancreatitis, can cause low diastolic blood pressure. Liver disease, inherently chronic liver disease, will have a low diastolic pressure, both because of nitric oxide. Severe anemia and thiamine deficiency are characterized by deficit of oxygen at the tissue level, so the cardiac output increases. And as a compensatory mechanism, the SVR decreases. And the low diastolic pressure is primarily related to a low SVR. Then again, in aortic regurgitation, to facilitate the forward stroke volume, there's a decrease in SVR, and we know the diastolic pressure can really fall in AR. And other causes of vasodilatory shock, and even in elderly atherosclerotic patients, there can be low diastolic pressure. We are all very familiar. We have taken the blood pressure in elderly. It can be like 160 by 60, etc. And that is due to a reduced Wind-Kessel effect. I shall refer to that in the coming slides. Now, moving on to something which is slightly more technical and more advanced. How do we calculate the stroke volume with our monitors in the patients? So this is pulse contour analysis, and I'm sure this is familiar to everybody. This particular trace I've showed. In the black is the systolic portion part of the arterial trace, and stroke volume is calculated as K into pulsatility. Pulsatility is calculated by the software in the monitor, right? The patient is hooked to a monitor, and pulsatility is calculated by the software. And K is a constant which is derived from the demographic data of several patients, and it accounts for resistance and compliance. So the monitor gives you the stroke volume, and you know the heart rate. The monitor knows the heart rate. It gives you the cardiac output. So that is how it happens in the pulse contour analysis method of giving you the cardiac output and stroke volume. Now, here are some basic traces. That is the aortic traces, and you can see here there's a normal waveform on top, and below that there's a low contractility. So when there's a low contractility, it's the upstroke slants, as you can see here. And there on the middle on top is a vasoconstriction. So when there's a vasoconstriction, the dichrotic notch moves upwards because the reflection waves come faster. You know, there's an incident wave, that is the ejection of the left ventricular stroke volume, which moves forward from the aorta. And as this moves forward, it hits the femoral arteries and the peripheral arteries, and their waves reflected back. And these clash together, and that is what gives rise to the dichrotic notch. It is not the closure of the aortic valve which gives rise to the dichrotic notch, as is mentioned in many books and as is believed by many people. That is incorrect. In the left-hand corner below, you can see high contractility. So high contractility means that the upstroke will be sharper, and if it's even more in the amplitude, that means the stroke volume is even more. So by just looking at this trace, the arterial trace, one can make out what is happening to the patient. One can take a baseline arterial trace, and if something is going wrong, one can take the trace again and compare, because eyeballing is sometimes difficult. So if I will just read out these few points. If there is vasoconstriction, then downslope of diastole is slanting. If there is vasodilatation, then downslope is vertically down. Stronger the contractility, steeper the upstroke slope. Larger the amplitude of the upstroke, greater the stroke volume. Now, a small question for the audience. If they want to answer, they can put it in the type box. I can see it in the end. There is a problem with vasoconstriction and vasodilatation trace. The vasoconstriction is going to be slanting like this, and vasodilatation is going to be slanting like this, because the SVR in vasoconstriction is increased. So the diastolic runoff is going to be much more shallower. It's not going to be so smooth, right? It's going to take more time. Well, if there is vasodilatation, the SVR is reduced, so the diastolic runoff will be abrupt. So that is the answer here. Maybe some of you got it right. So let's move on. Now, this is taken from Hall's textbook of critical care, which is a classic textbook for critical care. It's a very beautiful trace here. So I'm showing this to you. So on top is the normal trace. On the left side is the trace for cardiogenic shock and hypovolemic shock. And what I told you earlier is what is being shown here. The upstroke is less, the dicrotic notch has moved up, and this is because the stroke volume is less and because the SVR is increased. In cardiogenic shock and hypovolemic shock, the SVR is increased, right? And if you look at right, there's septic shock. In septic shock, if you have adequately filled up the patient, there's going to be a normal or a high stroke volume and the SVR is low. Thereby, as you can see, the upstroke is good and is going vertically up, is higher, and the dicrotic notch is moved down. So this is a very beautiful trace, comparative trace, and if you can actually understand this, it helps a lot at the bedside. Now, another misconception is all patients present with bounding pulse in septic shock. So this is classic teaching. We have been taught all this right from our undergraduate days, and even today it persists in the books, that septic shock is characterized by a bounding pulse and warm extremities. Is this really true? So more data has emerged now as people have realized, and their cardiac phenotypes in septic shock. So I'm showing you the results of a study which combined two echocardiographic data, echocardiographic data from two studies. And this is a dendrogram on the right side. This is not going to tell you too much, but if you look on the left, so here, if you see, there is LV systolic dysfunction in cluster 2, which is 17.7%, and patients with right ventricular failure, cluster 4, 22.5%. So together they make around 40% of the patients. Now it is understandable if there is LV systolic dysfunction as well as patients with RV systolic dysfunction, you're not going to get a good stroke volume. And if you do not get a stroke volume, which is good, you cannot get a bounding pulse, period. So you cannot always have a bounding pulse in septic shock, and we need to change this narrative in our textbooks and in our standard literature. Though the articles which are coming out now are very categorically telling what I'm telling now. But this should be realized by all, especially the students, the younger people, that all septic shock is not bounding pulse. Now moving on to something which is known as arterial pulse amplification. So as we move away from the central aorta to the peripheries, there is widening of pulse pressure. So the mean arterial pressure remains same. And this is because of something known as the Windcastle effect. The Windcastle effect is a classic model which has been used to describe this propagation or this amplification of the arterial pulse. So what happens is when the aorta ejects, when the heart ejects the stroke volume, it goes to the aorta. Now the aorta is a very elastic artery, so it expands, right? And it expands and it pushes the blood into the periphery. At the same time, reflection waves come back, and because of the incident and the reflection waves, you have this pulse pressure widening. So that is in a normal patient. However, in sepsis, this has not been shown to be true, and sepsis reverses the normal pressure amplification down the arterial tree. This was demonstrated in a very beautiful experiment here, and the tracings are there, but I will not explain this because I'm running short of time. But we should know this: in sepsis, the reversal of the normal pressure amplification, and even on vasopressors, this pulse wave amplification gets distorted. Now, pulse pressure depends on the stroke volume, the aorta elastance, and to some extent on peripheral artery elastance and resistance. The pulse pressure is less than 30 mmHg means low stroke volume, greater than 60 means high stroke volume. Normal small variation with respiration occurs. because of the heart-lung interactions. Elderly often have hypertension with wide pulse pressure due to stiff blood pressures like 160/70 due to decreased Windkessel effect. And pulse pressure less than 40 to raise a red flag for low stroke volume in hypertensive or atherosclerotic patients. And if low PP is improving fluid, it implies stroke volume improved and hence cardiac output improving. Now, very important is pulse pressure variation, which we use to assess fluid responsiveness. And this is normally seen in a ventilated patient. But if you get pulse pressure variation in a spontaneously breathing patient, you can use this for fluid responsiveness with varying sensitivity, but a high specificity. So that's very important because assessing fluid responsiveness in a spontaneously breathing patient is very important. Now, moving on to this, why cardiac output is the only variable which tracks fluid response accurately and pulse pressure, MAP, SVP are not good in septic shock. So one is baroreceptor reflexes which get activated, thereby activating the sympathetic reflexes when you push in fluid and the cardiac output increases and hits the aortic arch. Second is extreme vasodilatation. So even if you push in fluids, the blood pressure may not rise because there is so much vasodilatation. Then spontaneous changes in vasomotor tone can occur and they can be altered compliance or autonomic neuropathy. The PPV is pulse pressure variation. It is more sensitive than stroke volume variation and systolic pressure variation for fluid responsiveness in septic shock patients. So PPV, that is pulse pressure variation, there's less inaccuracy and noise in its calculation because it comes directly from the arterial line, right? There's no major calculation required, but stroke volume variation requires pulse contour analysis. Thereby, there is some noise in its calculation. And for systolic pressure variation, it gets influenced by not only the heart-lung interactions, that is in terms of the respiration, but also by the intrapleural pressure, which directly increases the systolic pressure. Thereby, PPV is the most accurate determinant for fluid responsiveness out of all these three parameters for patients who are on the ventilator and are being ventilated with 8 ml per kg. Now, why flow track, that is uncalibrated devices, do not measure cardiac output accurately in shock? So there are a couple of reasons. Stroke volume is equal to pulsatility into K. I told you K is a factor which is a constant depending upon the normal population and accounts for SVR compliance. Pathologic states of shock and vasopressor use alters K, that is SVR in compliance. Hence, there is non-reliability. And absolute values of stroke volume are thus not completely reliable in shock. Follow trends like increase in cardiac output with these devices, and they can be used for calculating the cardiac output and the response in passive leg raising test. And Wessling was the first in 1983 to devise this formula. Now, we are coming to the end. So this is a very sophisticated way to test fluid responsiveness and has been devised by the great professors Monet and Tibulle, and it requires the presence of an automated bed and a cardiac output monitoring device. However, this particular thing is not available in most of the ICUs in the world, right? Most of the ICUs in the world don't have such sophisticated equipment. So what is to be done in resource-limited ICUs? So in resource-limited ICUs, in a normal bed, you should gently perform the maneuver. You should know the maneuver. Do not cause pain. Do not cause tachycardia because that will negate the test because that means that the sympathetic discharges have been activated. So once you do the maneuver, that is the leg raising, if you notice an increase of pulse pressure, you need an arterial line, okay? So if there is an increase in pulse pressure to the tune of 20%, or if there is a decrease of pulse pressure variation on the ventilator by 20%, that can be taken as a sign of volume responsiveness in these patients. So this is very important because most of us are working in resource-limited ICUs. Now coming to a blood pressure of 70/50, what inference can you draw for the type of shock? You know, one patient comes to you in the ICU, this is the blood pressure. So can you tell what type of shock this is? So people try to analyze and say, maybe this is cardiogenic, maybe this is septic. But because the diastolic is 50 here, a lot of people will say this is low diastolic, so this is septic shock. But look at the systolic. Systolic pressure is only 70. So the pulse pressure is only 20. That means the heart is not pumping enough blood. So when the heart is not pumping enough blood, your diastolic pressure is going to be low anyway. So you cannot say what this is, right? So most of the times you can say, but many times you cannot. This could be anything: cardiogenic, hypovolemic, septic, or the forms of vasodilatory shock. Now, moving on to this, having said all that, please remember that you have to know whether your arterial line is giving you the correct reading, the correct pressure, and the correct trace. In the only study, proper study that was conducted, it was seen that 21% of arterial lines were not working normally. So this is very important. All what I've said becomes irrelevant if your arterial line is not working normally and you are taking the readings from that particular arterial line. So with that, I come to the end of my session. Thank you very much. I'll be happy to take any questions.